tackle a pretty tough subject, which is violence and abuse. And it's something that we are all going to encounter with our patients. And sometimes it'll be obvious and overt, and our patients will share it openly with us. And sometimes it'll be something that we suspect based on behaviors or actions. Sometimes it'll come completely out of left field based on something that they are, a behavior that we're seeing in labor. But no matter when we encounter it, it's heartbreaking, and it's a very helpless feeling, and oftentimes we feel like we have no ability to make a difference in these women's lives. My hope is that by the end of this lecture, you will feel like you can make a difference. Sometimes it's nothing more than the beginning to plant a seed, and your actions can begin to nurture her a hope that she can make change in her life. We know that a woman often has to be asked 7 times before she will admit that she's being abused, and oftentimes has to be asked up to 20 times before she will make changes and leave an abusive relationship. And knowing that she is being abused or has left an abusive relationship is really powerful for us, so that we can be cognizant of our actions and our words. So knowledge is very, very important, so that we can be mindful of our actions and our behaviors. And that is my hope and my intention with how we are with our patients every single time that we are interacting with them. So a Healthy People 2020 goal, and I hope, I've mentioned this multiple times throughout our course, I hope that all of you have at some point taken the time to go to healthypeople2020.org and read through them, especially the maternal child goals. We failed the Healthy 2010 goals. They've had to restate the 2020, and we're not going to meet our 2020 goals. But just to be mindful of what those goals are, it's so important that we are aware of what they are and what we are striving to do. They are really, really important goals. But one of the goals is to reduce the rate of physical assaults and number of rapes and attempted rapes. So many women experience PTSD after being assaulted, and can inhibit a survivor from adapting or coping in healthy ways. And we see that oftentimes they think that they have adapted or coped really, really well, and then something like childbirth will trigger them in ways that they didn't anticipate, because the sensations of childbirth can often mimic the sensations of their assault, and they didn't anticipate that or weren't aware of it, and it can all come flooding back to them at this most joyful of all times, and all of a sudden they're right back having this like PTSD moment. Sometimes memories that they have completely suppressed and are completely unaware of even having, oftentimes they're having this PTSD moment and they're not even cognizant of why or what or when or who or how, because they've so suppressed the moment. And so you're seeing them shut down their labors, not dilating anymore. You're just seeing this kind of classic child abuse pattern happening, and they're denying that anything ever happened to them because they've so suppressed the memory. So because the sensations of labor are so similar to what had happened to them in childhood, it's really agonizing when it happens, but it's important to then help them get through that and then maybe process at a later date. So, starting with rape, there are 4 recognized types of rape. Rape is defined as the penetration of the vagina or anus with anything. It doesn't have to be a penis. It can be any type of object into a person without their consent. It doesn't have to be a male and a female. It can be any genders. Acquaintance rape is a forced sex from a person that the victim knows. Date rape can occur with a dating or a marriage situation, and I want to be really clear that married people can be raped. A woman can be raped by her husband. A lesbian couple can rape each other. A gay couple can rape each other. So rape can occur within the boundaries of marriage. And we haven't recognized that so well in the past, but it is being acknowledged now. So just because someone is married, don't think this can't happen, and be very aware of that when you are in the clinic with them. Statutory rape is anything that happens someone over the age of 18 with someone under the age of 18. Even if it's consensual, someone can be convicted of statutory rape. So nearly 3 in 10 women and 1 in 10 men have experienced rape, physical violence, or stalking by a partner. Violence against women is a significantly growing problem. 40 to 60% of murders in North America are committed by intimate partners. And in the US, 1 woman is being battered every 12 seconds. And I didn't even include from the global perspective. It's much higher when you look at the violence that are done against women in countries where there is war and where rape is used as a weapon in a genocide or in one country against another. It is devastating when we look at those numbers. And a lot of those women who come to us as refugee status have encountered violence and rape as a status of war, and have hurts far deeper than we can ever imagine. Intimate partner violence is actual or threatened physical or sexual violence or psychological or emotional abuse. So this includes threatened physical or sexual violence, and when the threat is used to control the woman or the partner's actions. Other terms that we hear is domestic abuse or domestic violence. It can be gender-based violence, spouse abuse, battering, or rape. All of those terms are under the umbrella of intimate partner violence. Characteristics, usually the person who is the abuser usually is using or abusing substances, and it's worsened significantly when they come home under the influence of some type of substance. You'll hear stories about how people just feared when they came home drunk or even mildly intoxicated. Significant negative effect on their lives. The person who is the abuser always has a history of child abuse themselves, so let me be clear about that. All abusers, the research shows that all abusers were abused themselves. It doesn't mean that if you were abused, you will become an abuser. That's not what that means. But when we look at people who abuse, they themselves were abused. But not everyone who was abused goes on to become an abuser. I hope that's clear. But it is sad to know that all abusers, they were themselves abused. There are usually very traditional gender role expectations that he will be the he will be the breadwinner, she will stay at home with the children, very kind of traditional roles. And there's kind of this generational continuum of violence because that's a learned behavior and learned anger management. There is no such thing as anger management, it's just this learned way of behaving. So there's this cycle of violence, and it goes in phases. So in phase 1, there's this tension building phase where the violence is minimal. If it is, it's more verbal or emotional, more that psychological manipulation, where she just feels like, okay, if I do everything right, he won't get mad. If I keep the house clean, if I iron his shirts well, if the laundry is done well, if I act okay, he'll maybe get a little irritable, but he won't be mean, or he won't get mad at me. Phase 2, though, is when the battering actually occurs, the physical abuse begins, the victim feels completely, because he at this point is probably, I'm going to use terms of he and she, though please let me be clear that this isn't always a he and she thing. Sometimes the woman can be the abuser, or it can be a she, or he. But for just the purposes of this lecture, I'm going to assume it's a male and a female. Anyway, so in this phase, it goes to battering, and he's usually isolated her from family and friends, so she feels very isolated and alone with no one to turn to, so she feels very powerless, and she feels like it's her fault. So she may even deny that maybe he slipped or he was drunk, so it wouldn't happen, and he feels really bad, and he apologizes and brings her flowers, and so then they go through this honeymoon phase, And she really wants to believe that it was just a one-time deal. And then what happens is that the cycle continues to increase over time. We usually also see in this cycle that it will happen like maybe when they're dating, and then the cycle will intensify once they get married, because then he feels like, ooh, he really has her now because she's married to me. And then we also see a real increasing in the intensity once they have children, because once she's pregnant, then he knows he has her forever, because now they share this child. And once they share a child, he knows that she's stuck with him forever, and she can't ever leave him because they share kids. So when there's abuse in dating and there's abuse in marriage, once that we see that she gets pregnant, that's when we really see a ramp up in violence. And so as providers of women who are pregnant, it's so key for us to be watching, because this is really when we see that ramp up in violence. So that's why we want to screen them not only at the first OB, but if we can screen them again sometime mid-pregnancy and then again during the labor and delivery, it's very, very, very important for us to do that, because like I said, it takes at least 7 times before a woman will admit that she's being abused. So these are the types of abuse. It's not always physical. Emotional, physical, financial, sexual, and verbal are all the types. Abuse profile. So victims, they rarely will describe themselves as abused. They rarely see them, especially women who maybe who are educated, come from more wealthy backgrounds. Like, they don't want to see themselves that way. And this comes across all socioeconomic and cultural backgrounds. Rarely do victims see themselves as abused. They just don't want to see themselves that way. They may feel that it's their own fault, like they have some type of personality flaw. They're just maybe a little bit, they have too bad of PMS, or they've just done something wrong. They may feel inadequate in some way, and if they just did something better, he wouldn't be that way. So it's their fault. They themselves were probably abused as children, so this is a normative somewhat behavior, so they don't totally see it as abnormal. And so for them, they don't understand that this isn't how it's supposed to be. For the abuser, because they also come from a place of being abused themselves, they struggle with deep feelings of insecurity and powerlessness and helplessness, and they're so afraid that this woman is going to leave them. And they work from such a deep, deep feeling of fear that the abuse is a way to manipulate and control and keep her where she wants them to be. And it is all about power and control, and that violence is a way to manipulate, the isolation is a way to manipulate them. It's not obviously a healthy thing or a good thing, or he's a very bad thing that he is doing, but it comes from a place, when you think of him as a child being abused and hurt, I sometimes can't help but pity where he comes from, but he's turned it into something of evilness. So I don't have pity for him as an adult, but as a child, it breaks my heart to know that he himself was abused and is so broken that now his insecurity and powerlessness has turned him into this very evil person. So again, as I was said, the violence against pregnant women it's a time of escalating violence in an already troubled relationship. They usually, these factors of all of them put together leads to more increased battering, because he knows he has her now. So he's not afraid maybe he would only verbally or emotionally abuse. Now often in the pregnancy he will lead to physically abusing her. There's a lot of threats made during this time, and we'll see more and more signs of abuse that emerge during the pregnancy. So it's really important for us to be monitoring this. The signs that we can see are things like actual signs of physical abuse, signs of neglect, lots of emotional, sometimes sexual abuse, and then financial or exploitation. So those are all things to be looking for. Bruises that are unexplained falls, clothes that need to be washed, that she hasn't been showering like she needs to, or that she's not getting the food or nutrition, she's not picking up her prescriptions if she needs to. She seems more fragile or teary than what you would expect a woman to be in pregnancy. She's just more tearful. Maybe she's complaining of more UTIs or more vaginal infections, and when you do your exam, her bottom looks a little bit more bruised or torn. she's having a difficult time getting a ride to the clinic, or she's missing more appointments than you would expect. Like, those are all signs of things that you should have a high suspicion that the abuse is occurring. So there's more than just intimate partner violence. There's other types of sexual violence. So there's the intimate partner, like I said, there's human trafficking, which we know is starting to be more and more and more of an issue. I've already had students in clinical have signs that they're seeing that in patients that they're delivering. So these are signs of, young women that have had more than one baby, that are having a hard time making eye contact, that have strange relationships with the men, or more than one men that are bringing them to clinic, that aren't really connected with these men that are bringing them to the clinic. Incest is another one. Prostitution, which is another form of human trafficking. Exploitation or neglect, infanticide, sexual assault. These are all types of sexual violence. But there is hope, there is recovery. We hope that these women all choose to get into some type of therapy, because this is a long process. It's really tough to recover from any type of sexual exploitation or abuse without good therapy. Through this therapy, there are phases, kind of like the stages of grief. There's the stages of recovery. In this first kind of phase, they're in complete kind of a shock phase and very disorganized. There's lots of guilt and feeling unclean, like wanting to just be washing all of the time. There's nightmares. There's kind of like this PTSD, acute PTSD phase, I would call it. And then afterwards, they can kind of outwardly be calm and outwardly like adjust and start returning to normal life. But inside, they're still really reeling and maybe still having the nightmares. This is really when they're kind of almost in a denial phase with that. They might deny any need for help, like, I'm fine. I'm just going to like pretend it didn't happen, and I'm going to keep on, like, just keep on trucking. I'm just keep on going. And then in that reorganizational phase is when they realize that, like, the denying it and pretending that it didn't happen isn't working, and they maybe want to just like move across country, or they want to completely change jobs, or they have to move out of their house, or wherever. They just need to get away from where everything happened, and they try to emotionally completely distance themselves from coping. And even that after a while won't work, and then that's when they do the integration and recovery, when they start trusting again, they start feeling safe again, they do start getting into therapy, they start connecting with other people who have gone through this, and they understand that they can survive and they can heal and they can return never maybe to norm, what normal was before, but to a new normal, and they start growing and becoming stronger. So for us, like, what do we need to do to help support these women and men as they are recovering from this time? So they call it the ABCDES. So the first thing we want to do is the A, is that we want to reassure them that they are not alone, that we are with them, and there are others that can come alongside them that can help them through this time. The second is B, and we always want to make sure the worst thing that we can do is make someone feel like we don't believe them. Especially in those like acquaintance rape or date rape situations, we always want to tell the person that we believe them, and that we're going to empower them to take the steps they need to get the help, to get to maybe have the exam, and we're going to be by them through that because we believe them. C is confidentiality. It's so important, and it's sometimes a tricky road, especially when they are getting the rape kit done, or needing to give a police report and some of those pieces. But we will keep the information limited to just the people that we need to know, or that need to know. The only things that we have to be open about are if we're mandated reporters and there are children involved, we have to let them know that we will report the things we need to report, but otherwise we will keep everything else confidential. D is documenting, and thoroughly, especially in our exams, because that can make all the difference in the world, especially if it ever goes to court. We want to make sure that we are documenting everything we see. I would, especially in our prenatal care, if someone comes in with bruises that seem not consistent, like with the fall that she's having, or she or seen She comes in for vaginal itching and she's got bruises around the perineum. I would document that very, very thoroughly and document her explanation for why those bruises are there. If it doesn't align, someday she may want that documentation because she's going to press charges, and so you have that documented well. Educate, teach all the legal aspects, teach her the community resources, even if she doesn't want them and she slips them under the floor mat in her car or she slips them somewhere he can't find it. If you can give her the safe shelters that are in your area or the community resources that she can run to in the middle of the night, let her have them, because you never know when she might make the decision to leave. And so even if she doesn't, it's that planting the seed. Even though she might not take them today, she might take them tomorrow, she might take them at 2 a.m. Give her everything you can, because you never know when you might be the last person that she hears and needs to go. And S is safety. This is the absolute highest priority. It's especially when she's leaving. This is the most dangerous time. This is when we most often see if murder is going to happen. It's when she's trying to leave. So always help her identify a safety plan. Who can you go? Where can you go? When is it safe to leave? These are the who can keep you safe. How can you be safe? When is he gone the most? Like thinking of those places, it's safety for her and for the baby, for her children. These are the things. Having a safety plan is really, really, really important. Childhood sexual abuse. I mentioned this a little bit. This can really come back and haunt people, especially during labor and delivery. And so I did post a video by Penny Simpkin, who's an amazing childbirth educator. She's kind of the guru in the field. It's a very powerful video on when survivors of childhood sexual abuse give birth, and I really would like all of you to take the time to listen to that. I'm not going to reinvent what she's done here, because what she can say is way more powerful than anything I can say. So those are a couple of references of what I've used here. I do want to go through 2 case studies. So let's first look at this case study. So a 24-year-old woman was seen in the and I want to say I got these case studies. These are some residency case studies that are used. So these are not ones that I've developed. So a 24-year-old woman was seen in the emergency department at 2 a.m. for an alleged sexual assault. She reported that she was on a blind date and began heavy petting at about midnight. This continued for quite some time, and the date would not stop his advances. She stated she had been held down while her clothes were removed and was forced to have sex. She was tearful, distraught, agitated, and admit she had been drinking alcohol. The emergency department staff was very busy with a number of other patients. The gynecologist finally arrived at 4 a.m., although the patient had arrived at 2. No female assistants or standby could be found for another hour, so the exam began around 5:30 a.m. On physical exam, minor abrasions on the patient's back and several fresh areas of ecchymosis were noted on her upper arms and breasts. The sexual assault kit materials were used and lab specimens were obtained from the vagina, urethra, rectum, and oral cavity for analysis and culture. Fingernail clippings, hair brushings, and acid phosphatase swabs from the vaginal discharge were obtained. The vaginal discharge was examined and motile sperm were noted on a wet prep. Lab, cultures, swabs, and blood work. So, the plan, I didn't have this on here, was careful history and exam, specimen collection, take photographs of injuries, fill out and sign the chain of custody form, notify social services and the assault crisis center and the police, and arrange for proper follow-up care. So the questions are, how was this woman, when we look at the ABCs, going back to that, I'll scroll up to here. So, how was she helped and how was she failed? So was she alone? Was she believed? Was she confident? Was things documented? Educated, and safety. So it seems like the emergency department failed her because she came in at 2, and they did not even see her until 5:30. One good thing, though, is that they did not leave her alone with a male MD, so that was really good. And they did believe her in it that they did do the rape testing kit, and they did take pictures. Her injuries, from what I'm seeing, minor abrasions, ecmosis, did appear to be consistent with rape. So that is good. So we know that 50% of tests run 12 hours after intercourse will show acid phosphatase concentrations. So the exam timing is really, really important. If someone is raped, we want to get them into the ER within 12 hours. So that is something, or to get a sane exam within 12 hours is really, really important. So let's see, what did I write down here? Sexual dysfunction is common among rapists, and failure to ejaculate or erectile failure may make some internal vaginal specimens unhelpful. So often you see soft tissue trauma to the genitalia, and that's often the only corroborating evidence. So that's why there's lots of bruising, and you have to take pictures, which can be re-traumatizing for many of these women. And it's really important to go slow and to explain everything. Genetic screening is becoming a really, really important aspect of the sexual assault evaluations. All specimens need to be collected in the presence of witnesses and taken directly to the pathologist, and all your systems of collection and transports must sign, so there's chain of custody, so that there's no mistakes or exchanges in the specimens, because any break in the chain of custody makes it impossible to prosecute a case. The physicians and all of the witnesses will have to testify in court if the prosecution is attempted, so anyone involved needs to be willing to do that. So anyone you get involved will have to be willing to testify. I think that's all I want to say on this. Then let's look at our next one. This one's probably a little bit more intense here. AW is a 25-year-old G4P3 woman who makes an appointment to consult with us about her PMS. She complains that she is not herself for several days before her period and that she can't stop crying. She snaps irritably at her husband, who is a good provider for her and the children. She doesn't have her usual patience with the children, ages 3 and 2 and 8 months. She starts easily and is clumsy, and just last month she accidentally broke a favorite figurine her mother had given her. She thinks she might have felt better when she took birth control pills, but her husband doesn't think she should take drugs that interfere with her natural functions, especially with this PMS problem. He doesn't like IUDs, diaphragms, or condoms either. When you screen the patient for depressive symptoms, she denies appetite disturbance. Her sleep is somewhat fitful, but she has to keep an ear cocked to hear the children so that they won't disturb her husband as he has to get to work in the morning. Her energy and sex drive are not great, but she believes that's pretty natural with 3 children. She manages to keep up with them in the housekeeping. She enjoys seeing other people, but doesn't have much time for socializing. Her husband, who has accompanied her to the appointment, confirms her account. He says she would be a great little wife and mother if it weren't for this darn PMS. He remains in the exam room throughout the interview and general physical and pelvic exams, holding his wife's hands and patting her on the back from time to time. He tells you that you shouldn't worry about the cost of treatment because he wants his wife to have whatever she needs. Her physical exam is all normal except for a small bruise on her right arm. Labs, her hematocrit and TSH were normal. Assessment, possible depression, protective husband, bruise on arm, possible domestic violence. So just stopping right there, just think for a moment, like what signs in this history make you think that she might be a domestic violence victim? Just based on what's here. Just stop and think through this. I know it's in the middle of this lecture, so that's a big clue, but if this person came in, what would be in here that would make you think she had domestic violence or she was at risk for it? Because I'm looking at this, I'm wondering, she says she accidentally broke. She startles easily and is clumsy. So that makes me wonder, why is she startling so easily and what's making her so clumsy? So that's one line that makes me wonder. I would want to know why she's startling so easy. And the other thing that makes me uncomfortable is why is he in the room the whole time and why is he hovering over her? and he seems like he's being like very, I just want her to have whatever she wants, don't worry about the money, and he's all over there and patting her. It's very unusual for a husband to come to an annual exam and be in the room for the entire exam and pap smear. Like, that's odd. Most husbands, mine included, you couldn't pay $1,000 to come to the meeting. So why does he feel the need to be so up in her space? So that's the other thing that gives me pause. And then she doesn't have much time for socializing, sure, but why can't her husband watch the kids every once in a while and let her go out with the kids? And why can't she sleep? Like, why doesn't her husband let her sleep in once in a while? Like, yeah, he has to get to work in the morning, but that seems really odd too. Like, they're his kids. It just seems like she's really afraid. Like, the little things she's saying makes me feel like overall, the big thing is that she seems really anxious and afraid of her husband. So everything here is that's just giving me pause. And then I would want to know where a bruise came from. And the doctor doesn't seem, or this provider didn't seem to ask that. So then there's a follow-up. So AAW symptoms do seem to occur in the premenstrual phase, but it's not clear whether she meets the criteria for major depression or dysrhythmic disorder as well. But since the treatment for PMS is selective SSRIs, which are antidepressants, you reason that you will treat the depression as if it is present. After ordering a lab workup, you prescribe serotonin 50 milligrams a day, and you will arrange to have her previous medical records sent to your office. Prior to AW's return to visit, 2 weeks later, you review her records and notice that she has made numerous visits to physicians with vague complaints of headaches and abdominal pains over the years. She has also been seen in the ER department for a succession of lacerations and broken bones. Bruises were noted on these visits, but always explained by the patient. When AW appears for her visit, again accompanied by her husband, you ask the office nurse and clerk to engage him in a lengthy discussion of insurance benefits. When he is not present, you tell AW you are glad to have the opportunity to speak with her alone. She indicates that the medication has not made much of a difference in her symptoms, and you tell her that people sometimes have symptoms like hers when others in their home are hurting them, and that you have noticed many injuries in her past medical history. She looks frightened, and you assure her that you are there to help and you will keep her statements strictly confidential. She breaks down in tears and tells you that her husband's temper sometimes gets the best of him, and she says he would kill me if he knew I told anyone. You assure her that no one has the right to hurt anyone and discreetly provide her with information about domestic violence. After several visits in the company of her husband, AW comes alone one day and tells you, it took me a while to face the fact I was being abused and had to get up the nerve to leave, but one day my husband hit our oldest daughter and I realized I had to get out. The kids and I are living with my mother now, and I'm going to school so they can take care of us and make a new life. So, interesting. I know neither of these are antepartum, but just some interesting ways that domestic partner violence or intimate partner violence and sexual assaults can present. And I just wanted you to have some ideas on what that could look like. So I know that this is a hard topic, but it is something that I assure you that you will see in clinic if you haven't already. And I hope that this at least gives you a little bit of some guidelines. I'm going to put this ABC back up again, because I do think that this is really helpful. ABCDES is a really helpful way to frame the way that we can help our patients when they come in. And you're not going to hurt them or surprise them or make it worse by bringing it up. And in fact, you may plant that seed and give them the courage to do something about it. That's all I have, and I am here for questions anytime. Have a great day, everyone. Bye.